Okay, ma'am. We are starting the session. So it's my pleasure to introduce Ms. Shenbagam Narasimhan, a PhD scholar, a program head, assistant professor, and program coordinator, the Department of Optometry, School of Health Science in Sushant University, Gurugram. She has over 16 years of clinical experience as a senior consultant optometrist in specialty OPDs and glaucoma diagnostics at Shankara Nethralaya, Chennai. With expertise in OCT, UBM, HRT, and visual fields, an alma mater of Elite School of Optometry, she also served there as a faculty member for more than a decade. Her teaching interests includes research methodology, binocular vision, contact lens, pediatric and geriatric optometry, ocular diseases, and diagnostics. She is an active member of International Association of Contact Lens Educators, IACL, and a regular speaker at national and the international conferences. We are delighted to have her. So we are welcome back, ma'am.
Thank you, Ompriya, for this wonderful introduction. It's an honor to be here, and yes, we can start the presentation.
Thank you, ma'am. So today's presenter is a Madu Moashia. So she is an intern. So Madu Moashia, over to you. You can start presentation.
Good afternoon, ma'am. Today's topic is case report on progressive hyperopia. A 50-year-old woman noticed a progressive decrease in her vision in both eyes before 2 years. She was prescribed +1 diopters in distance. Spectacles obtained good vision, but her visual acuity progressively decreased even while wearing the glasses. Now she visited to determine the cause of a progressive decrease in her vision, ma'am. Here are the values. For visual acuity, best corrected visual acuity, she had a 6/6 with a power +2.50 with SIL -1.25 at 90. And in the left eye, she had a 660 with +6.50 with SIL -1.25 at axis 90. Her myopia is within a normal limits. In a slit lamp examination, a cornea was almost clear with no edema, and discernment fold in the central area. She had a fine pigments and opacities were detected in the superficial stroma of the cornea. And in both eye, anterior chamber depth length was very normal. And in fundus also, the present eye was normal. In ASOCT report, it shows a hyperreflective regions beneath the corneal epithelium and deep corneal stroma in both eyes. In CCT value, we had 541 μm in OD and 539 μm in OS, as determined with the help of pentacam we had taken. The refractive power in the central portion of the cornea is +40.3 diopter in right eye and 37.50 diopter in left eye, which are both weaker than the average normal value. In ASOCT report, both anterior and posterior surface of the cornea was flattened, both in bilaterally, and she had a bilateral irregular astigmatism values of the higher order aberration, were large about both the cornea and total eye bilaterally and especially in left eye, determined by a wavefront analyzer with the help of Topcon. She was prescribed a hard contact lens for a best corrected visual acuity to improve to 660 in both eyes. After 1 year, a progression of the decrease in the corneal refractive power determined in both eyes. The refractive power in the central portion decreased from 40.3 diopter to 37.6 diopter, and in left eye 37.5 diopter to 36.1 diopter in left eye with the help of pentacam we have taken. These results demonstrated the corneal flattening was continuing in spite of the hard contact lens wear. The differential diagnosis is CTK, central toxic keratopathy, usually occurs after refractive surgery and present with the corneal flattening and hyperopic shift. And interstitial keratitis, bilateral corneal scarring, can cause a flattening and irregular astigmatism commonly associated with syphilis. And next, the post-inflammatory corneal scare. Previous bacterial or hepatic keratitis may lead to irregular astigmatism and hyperopic shift. And the future endothelial dystrophy can show the discernment change but typically associated with corneal edema. And the corneal stromal dystrophy may produce stromal opacities and refractive. From discussion of early progressive hyperopia with irregular astigmatism, it's due to a corneal flattening. And pentacam shows a progressive decrease in central cornea power. K values reduce over 1 year. And CCT was within normal limits, thinning not the cause. And ASOCT revealed the flattening of both anterior and posterior corneal surfaces. And hyperreflective stromal changes suggest a stromal remodeling or fibrosis. And in increased higher aberration, explain the poor visual quality despite spectacle correction. Discussion, no history of refractive surgery, trauma, infection or systemic disease. Mechanism may involve stromal collagen alteration and abnormal extracellular matrix remodeling. Continuous follow-up with corneal topography is essential to monitor a progression. A flattening of the anterior surface of the cornea and both leading to the hyperopia and irregular astigmatism. It is relatively common for hyperopic shifts occurs in the eye with corneal scars such as that after bacterial keratitis or hepatic keratitis or TB. Interstitial keratitis due to a syphilis is usually bilateral, but this patient was negatively by blood examination. Central toxic keratopathy, or it is a rare complication after a lesion in situ keratomalicious or photorefractive keratoectomy. The abnormal secretion of enzymes or proteins from the stromal cells, TGFP induced proteins and TIMPS could promote a corneal fibrosis, which could then result in flattening in the cornea. Here the conclusion. In the presented case, it was a rare of progressive hyperopia and irregular astigmatism due to a flattening of the cornea. Thank you, ma'am.
Thank you, Madu Moashia. It was a great presentation.
Okay, so can I start?
Over to you, Shenbagam ma'am.
Yes. So, Moashia, it was a good presentation. However, I just want to know few things from your end. In this presentation, what is your take home as an optometrist? So you have presented a case, right? So I just want to know
Yes,
what is
ma'am.
your take or what is your message from this case to your.
I'm sorry to interpret, ma'am.
Tell me.
Can you be a little louder, ma'am?
Okay. So my question, am I audible now? Or am I audible?
Yes, ma'am. Yes, ma'am.
Thank you. So my question is, Madu Moashia, it was a good presentation, but I just want to know what are the things which you understood from this case, saying these are the parameters which a patient or an optometrist shouldn't miss in this case. So you were talking about the flattening of the cornea. So what is your take? Why is it happening, and how frequent or how rare is this phenomenon is?
Ma'am, we need to check the pentacam, and in the ASOCT only we had this patient condition, ma'am, whether how they having a thinning of the cornea, because due to the hyperopic shift also we had a it's a rare thing to had a astigmatism along with that hyperopic shift. So we need to have a proper checkup.
Okay, so now you have done pentacam, you have done
ASOCT.
yes, but what is the basic keratometry reading? First, we start from there, isn't it? As an optometrist, we check the subjective refraction, and we first do the objective, then we do the subjective. And then when there is a difference in the cylindrical power, we try to correlate by taking a manual keratometry, isn't it?
Yes, ma'am.
So where is the manual keratometry for this case? So we straight away don't advise pentacam. I think you got my question.
Yes,
So,
ma'am. I can understand, ma'am.
so first doing a refraction, this
Okay.
patient should undergo a keratometry, a simple keratometry test to understand the corneal curvature. So was it taken?
No, ma'am. Not taken.
Okay. So basically this message is to for everybody. So whenever you're doing a refraction and there is a progressive vision loss for this patient for a period of 2 years, am I right?
Yes, ma'am.
So in that case, any refraction, when you see some abnormalities, it is always important for you to document the keratometry value. So keratometry measures central 3 mm, right? So we should always measure the keratometry reading and then you correlate with your subjective refraction and then see whatever the salient features which you are describing is based on the slit lamp finding. Am I right?
Yes, ma'am.
So slit lamp finding is important. That is also very important. I agree that. But along with that, the other diagnostic simple clinical procedures which it is under optometry level, we should complete that as well. For example, in case of keratoconus, we should do differential keratometry, right? Like that, to
Yes,
understand
ma'am.
the corneal curvature, we have to do all these things. Second
Okay,
thing,
ma'am.
pentacam and other maps will show us. I do understand pachymetry thickness will show, but this should also be inculcated. Whenever you see a difference in astigmatism or flattening or whatever, more than 1.5 diopter difference, then definitely there should be a keratometry assessment. Clear, all of you?
Okay, ma'am. Sure, ma'am.
So
Thank you.
here, so here the point here is you are just trying to tell there is a shift in the hyperopia that may be because of the changes, and you have already narrated that because of the diseases. However, this patient has not had any blood investigations, was not um, revealing any positive result, and therefore it is something unique. Yeah.
Yes.
So the case you have chose is nice, but along with that, some additional documentation is required. That's all. Okay.
Okay, ma'am. Thank you, ma'am. Thank you.
Okay. So I thought since it is a hyperopia, I have some few points which I want to share in the form of PPT. So can I start that, all of you?
Yes, ma'am.
Yes,
Sure,
ma'am.
ma'am. You can start.
Yeah. I will just give me a minute. I am sharing the screen.
Okay, ma'am. Okay.
Is my slide visible, all of you?
Yes, ma'am. The slides are
Okay.
visible.
Yes, thank you so much. So basically, I'm just briefly going to tell the most, since it is as we have just um, refined a topic into hyperopia, I thought I will briefly tell you what are the basic things which we all should remember. Okay, so to all the people who have joined late, myself Shenbagam, and I am associated with Shushant University. I am taking care of the department. So let's quickly move on to this. So today I'll be talking about these few things, these are the things which I will be highlighting, and there will be one small question for you, all of you. That will be the last one. Maybe you can just randomly think and just let me know. If not, we will discuss that as well. So basically, this is related to progressive hyperopia. So whatever this is related to the case which she has presented. So my point here to put this case is, uh, basically whenever there is a central corneal scarring or changes, or as discussed in this case, it's a flattening. So you can see the central cornea here, it has a mild haze. So any person who is having a post LASIK treatment will have some changes. So one such changes is your central toxic keratopathy. So what is this basically? It is basically, it has some corneal opacification, striae. Striae are nothing but the lines here, the vertical lines or the cornea, and stromal bed tissue loss. This is basically a post LASIK complication. That's all I'm trying to tell you. So because of this, what will happen? There will be a shift. So there will be a hyperopic shift. This is what you have to understand. Okay. So now coming here, there is another complication called diffuse lamellar keratitis. So it has different stages: stage 1, stage 2, stage 3, stage 4, etc. So so why is the point we are addressing here? So you should not confuse with this and this. Both are different. So how are they different? So they are different in their own ways, where the diffuse lamellar keratitis DLK is steroid responsive, whereas the central toxic keratopathy is not. So it is there. You need not give any treatment, like particularly steroids. And here the clinical characteristics are different. There is no striae or refractive changes, whereas in CTK we did have. And there will be some conjunctival hyperemia and ciliary flush, which will not happen here. So how it will resolve? It resolve with this steroid. It's within a week, whereas this, it resolves 2 to 18 months. And this is because of the status post LASIK or PRK, photorefractive keratectomy. So maybe you can think, what are we supposed to know from this? Nothing, just take the proper history and understand the symptoms. See, whatever the patient are saying, that will be the symptom for you. So you have to take the history very properly, so that to understand and make sure that these LASIK complications are very very complicated. Matlab, you have to be very careful in understanding, because the treatment varies. As I said, one we are giving steroids, other one we are not. So your minute noticing things in the slit lamp and documenting is very important. That is the role of the optometrist. We are here for that. Okay, so your history will tell you the clear idea. Then you know how to focus with your refraction, and then go ahead with your keratometry, and go ahead with your other diagnostic procedures recommended. Okay, and again, these diagnostic procedures only we optometrists are doing. So we are not only oriented with the refraction or slit lamp evaluation or a routine comprehensive examination. We are just oriented in all the diagnostic procedures as well. So it is our responsibility to understand how to perform, how to analyze, and how to interpret the results or the pictures or the values. In this case, we talked about pachymetry. Pachymetry measures the central corneal thickness. Why central corneal thickness is important? Because in case of LASIK or in case of other thing, the corneal flap is removed, and we are trying to reduce the myopic shift. And unfortunately for few, we have some ectatic conditions and other things. So just to understand the corneal curvature. So all these things we have to understand. And second thing is, corneal thickness will come down once after LASIK. The thickness of the cornea will obviously come down, to understand this. But however, in this case, it was not done. That's what the case has been reported as a unique case. Okay, so here the procedure was not there, the disease was not there, but however, the patient developed these complications, which resulted in hyperopic shift. Okay, so now in this, I'm not going to talk more about this. Now I'm going to concentrate on hyperopia. What is latent versus manifest? What is absolute versus facultative? And what is this hyperopic anisometropia? So this is the basic crux in for an optometrist to understand when a patient comes with the refractive error. So what is hyperopia? So we all know, when parallel rays of anybody wants to define hyperopia, I'll be happy to listen. Anyone?
Yes, ma'am.
Yeah, please.
It's when the parallel light rays from a distance
Mm-hmm.
is focusing behind the retina.
Yes. So that is what when that is what hyperopia is. Okay. So first we have to know why this for what type of lenses we use to correct hyperopia. Anybody? There are three major refractive errors. One is hyperopia, second is myopia, and then is your astigmatism. So these are broadly defined under three categories. So what lenses do we prescribe for hyperopia?
Plus lens. Plus
Yes.
lenses,
Ma'am,
ma'am.
you use convex lenses, ma'am.
Yes. And for myopia?
Minus lens.
Yes.
Minus lens,
Minor
ma'am.
lenses. Yes. So this basic difference we all should know and we knew. That's nice. So now the next thing is latent versus manifest. So what is this latent versus manifest? So basically, we all know any refractive error which is hidden, that is called latent. The word latent means hidden. Manifest means when you do a retinoscopy, you will easily find out. Okay. So I will talk about that more. So here, a patient may have plus 2 hyperopia but shows only plus 0.5 during normal refraction. What is this normal refraction? A routine retinoscopy. Retinoscopy, you will have only plus 0.5 because the accommodation is constantly active. He will not accept plus 2. He will just accept 0.5. Why? Because he is having a good number of amplitude of accommodation based on his age. So how can we do this? How can we find out this? So first, when you suspect, I already say always said your history is very important. The clinical clue here is when a patient comes with you with the complaints of eye strain, that is asthenopia, but a minimal refractive error on dry refraction. So what is dry refraction here? When we assess the visual acuity and then we do the retinoscopy, that is before dilatation, that is called dry refraction. So the patient is coming with a symptom, but however we are not able to find the refractive error, we find just only 0.5. How is this possible? Only for this how can a patient can complain of asthenopic symptoms, etc. So in this case the right choice will be you have to ask for cycloplegia refraction. So what is cycloplegics? Any common cycloplegic which we do in the clinic? What cycloplegia you apply in this case for a hyperopic case?
Tropicamide, ma'am.
Tropicamide?
Yes, ma'am.
I use
Tropicamide?
cyclopentolate also, ma'am.
Yeah. See, tropicamide is only the dilatation of the pupil. There is no action of ciliary body muscle. We have to use cycloplegia. Why cycloplegia? Because it paralyzes the ciliary muscle. Why it is paralyzing the ciliary muscle, and what are we going to get? Because there will not be changes in the corneal curvature, lenticular curvature. For lens, accommodation is very important. So when we apply the cycloplegia, we arrest the ciliary muscle action. Therefore, accommodation will be paralyzed. So that is where cycloplegics play a very important role to understand what is the net refractive error without this accommodation coming into play. So that is called cycloplegia. Whereas this dilatation, the tropicamide, it just dilates the pupil. There is no paralysis of ciliary body muscle. Please understand, all of you. So it is just to see the fundus examination. So that is different and this is different. So for cycloplegic refraction, we have to understand what is the total amount of refractive error when the accommodation is null. That is when there is no action of accommodation. That is when there is no action of lens changes in the curvature. So that is called cycloplegia. So we have to do for all young patients and for all the patients who have the complaint of headache and eye strain and they are showing very little negligible error of plus 0.5 or minus 0.25, whatever it is, then you have to definitely ask this because they are showing symptoms. Is that clear? So from that we will find out. For example, in this case, if the cycloplegic refraction will be plus 3, we don't know. So from there we can understand latent. Latent means hidden. So to bring out the hidden, we have to use the cycloplegia and understand. So I have mentioned here dry refraction. So your dry refraction value and your cycloplegic value will give the difference of your hidden hyperopic error. Is that clear, all of you?
Yes,
Yes, ma'am.
ma'am.
Okay. Now manifest hyperopia. So I am just differentiating this. What is manifest? It is manifest means it is obvious, it is seen. So you need not do anything else, just do a normal routine refraction without cycloplegia, that is dry refraction will give you a value. For example, +3 diopter straight away, and he will be accepting +2, and that's fine. So this is the difference. Latent means hidden, manifest means it is very much significant and the patient accepts. So this is the two differentiation which you all should remember, because we are the one who will be advising cycloplegic and try to remove the symptoms based on the complaints. So as it is important, we have to find out. So the next is your absolute and facultative. So what is absolute and facultative? Okay, absolute and versus facultative. So absolute means total. Absolute, again, it is manifest or whatever. Absolute means whatever you are finding in your dry refraction, and facultative is your uh, which is uh, which is I'm sorry, can you come afterwards? I'm doing a presentation. So absolute versus facultative. So here it is because, see, here it is because of the amplitude of accommodation. For example, when a patient is coming with a problem, for example, you can remember this formula: total hyperopia is equal to absolute plus facultative. Again, facultative is which is controlled by the accommodation. For example, all the young children will have the very well amount of amplitude of accommodation. So if the patient is coming with a hyperopic correction, for example, +5, and he is able to accommodate +1, and based on your cycloplegic refraction you are giving +4, but what is the total facultative? You have to subtract total minus absolute. So this is what it is. Now coming to hyperopic anisometropia. So I think I'm clear with all the concepts, right, all of you?
Yes, ma'am.
Okay, so now I'm going to show the cases so that you will understand better. Okay, I'm sorry. Okay, fine. So just see this case, all of you. This is a case one, a 3-year-old male, right eye deviating inwards occasionally since 1 year of age, and the cycloplegic refraction is OD +5 diopters and OS +1. So what do you understand from this? Quickly.
Ma'am, from this case, the
Hmm.
deviation, the inward deviation of the eye is due to the high amount of hyperopic prescription in the right eye, ma'am.
Okay. So imagine the age of the patient is 3 years. Okay. And here the amplitude of accommodation will be really, really good. So therefore, the child try to accommodate all the +5 and above. That is why the eye is going inside. You all get it, get my point? However, this is the cycloplegic refraction which clearly shows +5, whereas left eye it is 1. However, the refractive error in the left eye is very less. But however, the refractive error in the right eye is high. That is why the child is showing deviation. That is maybe an esotropia or whatever. Okay, so this is case one. Just observe these cases. What is the second case? A 5-year-old male complains of asthenopic symptoms, and the unaided vision is right eye 618 and N10, whereas left eye is perfectly fine. Again, the cycloplegic refraction is this. So there is a difference between these cases, isn't it? Yeah. So here the visual acuity is less for the right eye and it correlates with your cycloplegic refraction. But however, the symptom is because of this 618 vision with the higher refractive error. That is why the child is having asthenopic symptoms. So I hope you know what is asthenopia. So I need not go much into that. Okay, now case 3. So a 15-year-old female complains of blurred vision, noticed suddenly on occluding the OS. So the child is having blurred vision in the right eye. But what happened here? The child accidentally closed the left eye and then only she came to know that their vision in the right eye is less. And imagine the cycloplegic refraction here. Yeah. So again +5. So here what I'm trying to tell you here is all the refractive errors are +5 and +1. So what is this called? What is this kind of refractive error called? And I have mentioned in the overview itself, I have given the clue there. So what is this?
Ma'am,
There is a
this is hyperopic anisometropia.
Yes. So there is a difference in both the eyes. There is a difference in refractive power in both the eyes. So obviously this is an anisometropic hyperopia. That's it. However, the different management here will vary. Why? Here the age of the child is 15. And this eye, if uncorrected and she had come here, it will be diagnosed as amblyopia. Right? What is amblyopia? It's a lazy eye. Why lazy eye? Because she noticed only uh, now, maybe by closing her left eye. So therefore, the efficiency of the treatment varies based on the plasticity of the age. Younger the age, she will definitely go for 6'9" or 6'6" with therapy. However, here it may take time and we don't know how much is the prognosis because she had just come at 15 years of age. However, here we can definitely try to give. Okay, so all these nuances you should understand when you are taking a history, when you're taking when you're performing the subjective refraction or objective refraction. You have to understand all these things. So without this, we will not able to proceed further to how to analyze the case or how to manage the case. The prescribing pattern of glasses varies for all these age groups. Please remember that the different age groups and the method of prescribing glasses varies. For example, this patient may or may not have diplopia, and how are we going to manage that? And how are we going to compensate for the loss of visual acuity? And how are we going to give the therapy? And what type of occlusion treatment we are going to give? Is we do we have to think about penalization, or we have to think about part-time occlusion? Or so there are so much of variations in this. However, there should be a periodic follow-up. Irrespective of the age, you have to do the follow-up. Without follow-up, then the patient's vision will not be sustained for a longer period of time. Then loss of follow-up, and again the patient may go back to the original state. So the message here is, see the case properly, diagnose efficiently, and do the appropriate treatment. Plus, counsel the patient that the child has to come for the regular follow up, okay, to enjoy the binocular vision, or else it will be difficult. So, we optometrists should counsel the patient very clearly so that they can understand the seriousness of their vision. Okay, so the next case is 6-year-old female, reduced vision detecting during school screening. So how many? I hope all of few of you have would have underwent school screening programs. Yeah.
Yes, ma'am.
So you should have understood what we are doing there. We do vision check, we do pinhole vision, we do retinoscopy, and we try to do the acceptance. And based on that, we decide whether cycloplegic has to be done. And based on the visual impairment, we decide whether the patient has to go to the tertiary eye care center, or the patient you can dispose there by giving the glass prescription and asking them to visit after 6 months. All these things are there. So that's why school screening is also very important. So here the patient had right eye 624 and left eye 69, and the cycloplegic refraction. So what is the unique finding in the cycloplegic refraction? Can anyone tell? You can just observe the finding and just tell me. Everything is there in front of you. Anybody? There is something different in the cycloplegic refraction. What's that?
Yes, ma'am. From the outcome of the cycloplegic refraction, the spherical power are the same, but the astigmatic prescription is more in the right eye compared to the left eye, ma'am.
The astigmatism is more in the right eye compared to the left eye, right?
Yes, ma'am.
So in this case, what are the additional tests we are supposed to do? Anybody else?
Ma'am, it is a compound hypermyopia.
Okay, then what is the additional test which you have to do? Apart from this, what else we have to document? Keratometry? Yeah? We have to
Yes, ma'am,
perform
keratometry.
keratometry. I have already told you, anything above 1.5, you have to make sure that you have to document the keratometry reading, because there it can be an internal astigmatism also, right? So always, whenever you see a number next to the spherical equivalent or next to that the astigmatic prescription of greater than 1.5, please take the keratometry reading. Okay, so that is next it is. So you have to take the keratometry reading. So you have to document and you verify it, and the astigmatic error can be because of lenticular astigmatism also. To differentiate that, we have to do this cycloplegic refraction. So this is what it is. Okay. So here the point that it is different compared to the other 2-3 cases. There it is only spherical component, but here I just want to show the astigmatism component of hyperopic refraction. That's why I've shown this here. Is it clear, all of you?
Yes, ma'am.
Okay, fine. So I hope I'm clear. So we have to see, you have to call for post mydriatic test for all the things. We have to do a post mydriatic refraction. So finally, to understand which prescription you are going to give based on your cycloplegic and your dry refraction. Okay. So now, as we all know, there is a difference in the refractive error between the two eyes in the above cases which I have told you. So the difference between the two eyes by 1 diopter or greater, and what will happen is they induce an image size difference. Plus 5 will show a magnified image larger and compared to the left eye, which is just plus 1. So therefore there will be a image size difference. As a result, patient may complain of double vision, and that's why it tried to suppress his one eye, and therefore the eye becomes lazy, and there it landed up to amblyopia. So all these things you have to understand. Amblyopic risk is high in hyperopic errors compared to the myopic errors. So what's next? Okay, ma'am, you're saying diplopia. So what's next? So what's next? You can always think about contact lens. When there is a difference in image size because of the spectacle, we have to nullify that. So how can we do that? We have to give a contact lens for the other eye. For example, in this first 3 cases, we can give contact lens to one eye, that is your right eye. If the patient is comfortable in this contact lens handling thing, you can give for both the eyes, no harm. But however, if the patient like 3-year-old, all this, we have to see the other factors which is very important. Therefore you can give for right eye alone, and you can teach for the parent how to orient the lenses and all these things, because we have to think about amblyopia. So that is more important. For a 15-year-old child, I think she can manage by herself if we teach properly. Training should be given, CL training, and we have to follow up. For every case, for every kind of problem, follow up is very, very important. I'm stressing this here because there are many complications because of this loss of follow up. It can be very simple negligence, that's all. And the patient would have landed up in infection or some other problem, which costs for almost another back to form, and it will take time to again come back to the normal curve. So you have to remember that. Okay, so next, in adults, so these are the things which we discussed in for the younger children. Okay, now for adults, this anisometropia can be due to trauma or ocular pathologies. In this case, it was an ocular pathology which we discussed today. So that is because of the flattening of the cornea. It's because of the ocular pathology, though we don't know the cause. And meridional amblyopia. So what is meridional amblyopia? In this case, we talked about -4 in the right eye at 180 degree, axis 180. So here, if you leave treated, that particular axis meridian will have a problem, and they will have amblyopia in that particular thing. So that is called meridional amblyopia. So this is possible only in the astigmatism error. Please remember that. And as I said, if the child is not having equal vision, then definitely the stereopsis and binocularity is a major factor of concern which we all should understand. So therefore, the bottom line message here is your dry refraction is very, very important. Okay, you can think, no, ma'am, it's okay. We can do autorefractometer. But do you think the child will be cooperative for that? Example, this 3-year and younger than that. So I'm not saying don't do autorefractometer. Please try the retinoscope value. Try to find some value, and then you can cross check even in the initial stages. But once you gain the confidence with your retinoscopy, I would say retinoscopy is the best thing that we can improvise our skills. And many times autorefractor will say no target, or if there is a keratoconus, no target, or if there is a congenital cataract, no target. So even if it is a media haze which it cannot retrieve, then it is a no target. So for all these complicated case, definitely retinoscopy will help you a lot. This I can tell you with a great amount of confidence, because I have done that. I've seen so many cases, so I can confidently say this. So even it's not late. Even now, from today onwards, take things seriously. Per day, at least one or two cases. If you try to scope, okay, if I move this way, this is with reflex, so this is hyperopia, so I have to put plus lenses. Okay, if it goes in the agaze moment, I have to put minus lenses. So it is an myopic refractive side. So slowly, if you start gaining practice, definitely you will be well versed. In another 6 months you will be really surprised, oh my god, I can do this much. So just the starting problem will be there for all of you, just maybe a day or two, then you will get practice, and then you will say, okay, I can find it. So what is my message here is, for all the cycloplegic refraction or dry refraction, your skill is more important, your retinoscopy skill is more important before handling all these different unique cases. So why I'm saying cycloplegic? Because the pupil will be dilated and you have to concentrate on the central reflex, because you will peripherally you will see some other reflex and centrally there will be some other reflex. So you will be little dilemma, what should I do, what should I put? So you should be always concentrate on the central reflex and try to neutralize it whenever the pupil diameter is large. So all these comes with a practice. So just try doing it and you will find the difference for yourself. Okay, so this is related to uh, hyperopic anisometropia. So in children, what we are supposed to do is try to prescribe the full cycloplegic refraction to prevent amblyopia. We discussed enough, and look for suppression. So what test we do for checking for suppression? How do we know whether the eye is suppressed? Anybody?
Ma'am, we can use what for dot, ma'am.
Excellent. So we can use Rutherford dot test to understand which eye is suppressed, like right eye or left eye or whatever. So associated with above symptoms, we decide the management of amblyopia, whether it requires occlusion or whatever. So this and all I have discussed very well. So I think it's time to move on to the next. So however, in adults, you prescribe glasses based on the tolerance level, improvement in the visual acuity and the visual need. See, straight away you can not give full correction and say, okay, sir, you are done, you can go. No, patient will not adapt. So try to go in small slots and ask them patient to come back, or you do a telephonic interview over the phone with the patient's consent, asking how is he comfortable, or is there any problem, or what is the other options, or ask him to come back. Some patients will lose interest and they'll throw away the lenses, I'm telling you. So whether it is new glasses or whether it is presbyopic glasses, first time wearer, all these first time people will have some like they will not be comfortable, and as a result they will lose interest and they will not come to you, or they will just leave it like that, okay, let me manage. So always follow up the patient. If they are not able to come, at least if you have asked for 3 to 6 months review and you feel the patient has not come, then it is our responsibility to trace the patient and do some telephonic interview and understand the problem. Okay, so maybe if the patient is not comfortable, we can try the other possible methods for treating. So once again, CL is the best option in all age groups. So, and there are many other things also. Okay, so just that counsel the patient, and your skill and knowledge plays a very important role in managing the patient. So here, the next is the progressing. This I want you all to observe the case, and please tell me what is your opinion on this. A 35-year-old female presented on 5th January 2026 with the following complaints. So what is the complaint? The patient had a sudden painless loss of vision since 4 days associated with a curtain falling sensation, and there are some floaters. Of course, there are no complaints of black spots and flashes, and since 6 months the patient has been observing floaters in front of the eye. The past ocular history, the patient is a known myope and it is -16 with this refractive spectacle prescription, 0.25 cylindrical in axis 180 and -17 with a 0.5 cylindrical axis 180. So the patient has told that I was being diagnosed as retinal plaque and vitreous opacity in both the eyes. So we don't know what's, let's see. So now coming to the refraction, the right eye vision is this much and the left eye vision is 2 by 60, 6/9 and 2 by 60 respectively. And the prescription is this, which we have seen already. However, in retinoscopy, there is a minus 18 diopter with a minus 1, axis 20. And in the left eye, it is plus 12 with, and minus 0.75, axis 170. So this is the acceptance. There is not much of an improvement in the vision for the right eye 6/9, and there is no improvement in vision in the left eye. So here I want you to all note that there is a huge shift in the refractive error in the left eye. Do you all agree?
Yes, ma'am.
Okay. So and Hirschberg, it is orthophoria, and you should know why this patient we didn't do cover test. I think you should apply your logic, and definitely yes, we cannot perform, so we did this. And extraocular motility was full, free, and painless, and pupil was brisk and reacting to light. However, OS had an RAPD. So the slit lamp finding was a little unique, where everything was normal except the intraocular pressure, where right eye was at 10 and left eye was only 0.2 mm of mercury. Okay, so posterior segment myopic fundus tilted disc, dull glow in the left eye, and with an horseshoe tear, lattice, and something else is major missing. So now I want the person who have not answered can answer this, because we should give chance for others also. So can anybody tell me what could be the diagnosis? Never mind, you're wrong. It's okay. We are just learning. Whatever comes to your mind, you can just share. So I will show the screen again.
It's a retinal detachment case.
Okay, how do you come to that conclusion?
In retinoscopy, white reflex is there, and in
Okay,
IOP also very less.
very good. So why there is a white reflex? Why? It can be retinoblastoma also. In retinoblastoma also we will get white reflex, isn't it?
But IOP also very less now. In aortic
Okay.
case,
Okay, so your point is IOP is less. So what is happening actually? Why the IOP is less? Any other
uh,
idea?
because of retinal detachment, globe will be stopped.
Okay, very good. Okay, so here this is what it is, and she has picked it up, and it is this. So what you can see in the screen, total retinal detachment in the left eye, right? So that is the reason the patient showed a plus, higher plus here. So the crux here is you should understand the history properly. See, there is a myopic history since 22 years. Suddenly, how can a patient go for a plus 12? So here you have to understand, no, something is terribly wrong. So we have to understand. And then whenever there is a retinal detachment, what is retinal detachment? Separation of the sensory retina, right? So that is called detachment from the RPE, retinal pigment epithelium. So since the retina is detached, there is a loss of aqueous humor just drains towards the suprachoroidal space, and therefore there is a reduction in the intraocular pressure, and that's why we are having 0.2. So this is very important to understand, so that this patient has to undergo the surgery immediately. We cannot wait anymore, because that is a threat for the patient's vision as well. Here it is only 2 by 60. So the management of this case is laser photocoagulation for the left eye, and right eye, because of this lattice and other degenerations. And the left eye, the surgery typically they advise for retinal detachment is scleral buckling with a vitrectomy plus belt buckling. You would have seen many case reports saying SB plus VIT plus BB plus EL plus SOI. So most of the like whatever the reports you are having in the history, it will not be full form like this. I just wrote because you should remember all these things. It will be like SB plus VIT plus BB plus EL plus SOI. After 3-4 months, they will do SOR. So what is SOR? Silicone oil removal. Okay. So all these things, whenever the patient is having an SOI, definitely the patient has to come for another surgery to remove the oil, because there will be secondary changes in the eye because of SOI. For example, the patient can develop into secondary glaucoma and many other complications because of silicone oil. Therefore, for the problem, we have to do scleral buckling. But however, we have to do SOI. But later stage, once the prognosis is better, they will remove the oil. Is that clear, all of you?
Yes, ma'am.
Okay. So that is all about it. Any doubts? And these are my references. And thank you for your patient listening.
Students, do you have any doubts? If you have doubts, please leave in a chat box. No doubts as of now. No doubt, students? If there is no doubts, we'll wind off the session. Thank you, ma'am, for your enriching, insightful session. The clinical pearls and the subtle nuances you shared added a great value and practical clarity to the discussion. We are truly grateful for your time and expertise, ma'am. Thank you for sharing all the knowledge, ma'am. Thank you so much, ma'am.
Yeah, thank you. Thank you for this opportunity as well. Thank you, students. Thank you. You can feel free to reach me anytime. If the students have any doubts, you can just reach me, Om Priya.
Sure, ma'am. Sure, ma'am.
Okay. Thank you.
Thank you, ma'am. Thank you so much.
Thank you so much, ma'am.
Welcome.